Good evening, aspirants of EDIC Part 1 crash course and Dr. Neeraj Kumar and Dr. Asif Iqbal sir. Today's class is on obstetric emergencies. It will be taken by Dr. Neeraj Kumar. Sir, you can take the class now.
Yesterday, I have covered the two important aspects like hematology section and endocrine, and I hope that you all guys have must got some time to read those important aspects. And even if you have not read after today's session, you must be going to read all those things because it will be helping you a lot in your upcoming examination. So, obstetric emergencies, just like your hematology and your endocrine, it's again a very important aspect. So I will be going to touch few important things, few important topics that could be asked in the exam for your EDIC 1 exam. I have also typed something for you all guys so that in meanwhile in between the class we doesn't get disturbed. And if you have any query in between, definitely you can unmute and ask the question, or for all those questions that what we are going to discuss today, you can definitely write all your answers in the chat box. And another thing is that I will be requesting all of you that attempt all those questions, even you mark it right or wrong, it doesn't going to make any sense because we will be discussing here all those statements that why this question is true or why this is false. Okay, so let's start. So first question is that which of the following statement is true in pregnancy? So it's a physiological changes that the question has been framed like that. And I think it is related to the physiological changes or physiological adaptations in pregnancy, especially in a hematological system. So it is going to increase in the platelet count. It is going to increase in protein C and S. So it decreases prothrombin time and activated thromboplastin, partial thromboplastin time, APTT. And then it decreases the activity of hemolytic factors like PA1 and PA2 inhibitors. So any of you who want to attempt, it's fine. Otherwise, the the answer is C. Now, why this answer? Because we all know that the pregnancy is a procognate state, and if you'll see the various hematological changes that you always know that there is increase in plasma volume, and it is always more, plasma volume is always more than increase in red cell volume, and then there is also a dilutional reduction in the hemoglobin concentration as well. Then there is neutrophilia, and then there is thrombocytopenia also, in which 10 to 15% of the reduction in the platelet count is there, and the pregnancy is overall a hypercoagulable state. So there should be a decrease in prothrombin and APTT values. Now coming to the next question, again a fact-based question that which of the following is as a maternal complication, in which of these findings you will get a hepatic capsular rupture. I have added few questions, a few new questions here also, so that you can know a bit more multiple choice questions or a bit more important facts that what is the maternal complications. Means hepatic capsular ruptures is mostly seen in which disorders like HELP syndrome, TTP, severe preeclampsia, or acute fatty liver of pregnancy, or antiphospholipid antibody syndrome. Anyone who wants to attempt this question? I think it's only one answer that is right.
HELP syndrome.
Okay. So you are going with the HELP syndrome. Anyone? I think yeah,
Yes,
you can write on the chat box, please. Yeah. It will be fine. Otherwise, okay. So Adil has attempted A. Okay, not an issue. So the answer is preeclampsia. That is answer is C. Why? Now you just see that why this answer is. Now you see that in severe preeclampsia, there is you see all those findings, but here we ask about the maternal complications. So preeclampsia, acute renal failure, and hepatic capsular rupture is a very peculiar finding of severe preeclampsia. Although in your HELP syndrome, you get a hepatic hemorrhages, not hepatic capsular rupture. That's why this question is important. But if you'll see the viral hepatitis, the hepatic coma-like state will be there, right? So in cases of acute fatty liver of pregnancy, hepatic failure or fulminant hepatic failure will be there. But a very specific hepatic capsular rupture, if it will be asked, maybe the answer would be severe preeclampsia. But if you further dive, or you want to dive in furthermore in TTP, again you see there is a diffuse subcortical microvascular disease, but it is not specific that whether it is due to in the hepatic only or liver only. But for liver, in severe preeclampsia or in acute fatty liver or pregnancy or in HELP syndrome, there are three different presentations like hepatic capsular rupture, hepatic hemorrhages, and then fulminant hepatic failure. I thought now it is very much clear for you all. Okay. Now coming to the next question, that which of the following test that now I want to ask that which of the following test is best that distinguishes between the acute fatty liver of pregnancy and HELP syndrome. So here the option is serum bilirubin, ferritin, serum ammonia, and liver biopsy. So you can write on the chat box if you want. Anyone who okay. I think Neeraj has attempted option C. Good. So I think he has marked it right. The answer is definitely serum ammonia, answer C. But here we have to understand the Swenson criteria, because this is very important for you all to understand that what are the laboratory features. Maybe they will be asking all of the following parameters are findings of acute fatty liver of pregnancy, except. So there are 6 parameters out of which you have to 6 of the features below are required for the diagnosis. So here, if we will talk about the laboratory features, so bilirubin should be more than 0.8. Hypoglycemia, it should be less than 72. WBC count more than 11, and AST or ALT value should be more than 42. So ammonia will be more than 47 micromole per liter, and your serum urate level would be more than 300 micromole per liter. So you have to remember these values. And apart from that, there is a microvascular steatosis on liver biopsy. So most of the time, it has been also asked that there is microvascular and macrovascular steatosis on liver biopsy, especially in cases of acute fatty liver of pregnancy. So you have to know that values also, that these are the few specific pathophysiological findings that why this is important. So this is the only thing which differentiates a acute fatty liver or pregnancy from HELP syndrome, if you'll go with that criteria also. Now coming to the next question. So which type of shock is found on initial presentation of amniotic fluid embolism? So in amniotic fluid embolism, which type of initial presentation of which type of shock you think that would be present? Like cardiogenic shock, cardiogenic and hypovolemic shock, distributive and hypovolemic shock, cardiogenic and distributive shock. Okay. So Adil feels that its option is C. I think he marked it right. So option is C. Now you see why. Just for a brief uh, about amniotic fluid embolism, we know that it's a very rare complication, but it has a very high mortality rate. It also occurs in 1 into 8,000 of pregnancy, and even the national registry data shows only 15% of these patients survive without neurological deficit. So what happens in these patients, that these occurs acutely during the labor and or delivery or during immediately at postpartum. So it may be asked that what will be the exact presentation of these amniotic fluid embolism. So it may occur during the labor and delivery or immediately at postpartum. So classical amniotic fluid embolism present with your hypoxia, hypotension with shock, and then altered mental status and DIC. Maybe few of the patients have pulmonary artery hypertension as well, which and later on it is replaced by acute left ventricular failure, and some patients may present with seizures. So it is always a diagnosis of exclusion. So differential diagnosis that you must be keep it in mind is your pulmonary embolism and then hemorrhage, and then sometimes acute myocardial infarction as well. So these are the few important DDs that we have to remember also. Now this is a very important very important chart. If you'll see that how these diagnosis or how these pathophysiological changes would be there. So here what happens, that amniotic fluid or fetal antigen exposure will be there, right? So what it would do, it has 4 or 5 different fates, like it can release the immunological release of mediators in the form of surfactant, endothelins, prostaglandins, arachidonic acids, or your phospholipase A2, and then maybe directly affecting the mechanical obstruction. So because of that mechanical obstruction, the cardiopulmonary effect will be there, leading to right ventricular failure, or these patients have acute pulmonary hypertension or hypoxia. So these three findings will be there. So cardiogenic property we can understand. And then after that, these patients may have complement activation. Again, on complement activation, again, biochemical mediators will release. And then coagulation system activation leading to consumption coagulopathy, leading to cardiopulmonary collapse and death. So all these findings will may be leading to presenting these because of mechanical obstruction and other presentations leading to this cardiogenic as well as the distributive pictures of shock. So you must remember that how these amniotic fluids of fetal antigens is going to affect all your organ. And later on, if the patient have right ventricular failure, later on left ventricular failure or biventricular failure can occur as a consequences in amniotic fluid embolism. And maybe these patients present with acute respiratory distress syndrome as well. Few of the neurological deficit is also present. Now coming to the next question about peripartum cardiomyopathy, that all of the following statement is true about PPCM, except in development of heart failure in the last month of pregnancy or within 5 months postpartum. Prognosis is dependent on normalization of the left ventricular function. The end-diastolic dimension of left ventricle is more than 2.6. The M-mode fractional shorting is less than 30%, and bold regimen is used for acute PPCM. So again, I have added a new question here. It might be not in your mock previous mock class, so I have just added. So which of the following is true? All of the following statement is true except. Anyone who wants to attempt? Okay, good. So here the option is D. Why? This is the only statement which is false. Rest all other statements are true. Why? Board regimen is used for acute PPCM. And then these development of heart failure, always PPCM last month of pregnancy or within 5 months of postpartum. So within 5 months is option is there, within 3 months, within 4 months, within 5 months. So it may be one of the correct answer. And then you must see whether it is a last trimester of pregnancy or not. So last trimester of pregnancy and within 5 months of postpartum is the ideal age group for the development of the heart failure. If the heart failure is developing, so maybe one of the diagnosis PPCM, but you must see the other findings as well. Like here, the prognosis is dependent on the normalization of the left ventricular functions. Yes, because the prognosis is directly dependent on the left ventricular function. If the left ventricular functions appears earlier or improvement in the left ventricular function will be there, the prognosis is more better in PPCM. And then in diastolic or EDV or EDD, in diastolic dimension of left ventricle is always more than 2.6 centimeter of per square meter square. And board regimen is used for acute PPCM. Now you see, so I have added 2 questions. Then after that, we'll discuss PPCM in a brief. So peripartum cardiomyopathy diagnostic criteria include all except. So heart is dilated. I think answer is written. Heart is dilated and ejection fraction is reduced. Heart failure may occurs up to 5 months after delivery. And then pre-existing dilated cardiomyopathy, which worsens during the pregnancy, and no other cause of heart failure is identified. So here, if a patient is having a pre-existed dilated cardiomyopathy, which wasn't during pregnancy, this diagnostic criteria is not included, whereas other diagnostic criteria is a part for diagnosing PPCM. Now let's see how it looks like. So if we'll talk about peripartum cardiomyopathy, first point I clear that it appears in the last month of pregnancy or at the end of the 5th month postpartum, right? And then for the diagnosis, it requires at least history of no cardiac dysfunction or no identifiable cause of heart failure, and there should be a new onset of left ventricular systolic dysfunction. So how will you know that your patient has developed a left ventricular systolic dysfunction? By seeing 3 things. First, your ejection fraction must be reduced below 45%. Second, if you'll do a Doppler and you will see a M mode, on M mode, there is a fractional shortening and it should be less than 30%. If you want to measure the area, so it should be more than 2.7 centimeter per meter square, that is in diastolic dimension. And on M mode, there should be a fractional shortening. So shortening is less than 30%. So if you want to see the further, you just see that how it looks like. So here, the diagnostic criteria, just what I have enumerated right now. Here also you can see that these are the additional findings, and these are the classical findings. So all four of the following is required for diagnosing your peripartum cardiomyopathy. Now, for classical, the patient should have a cardiac failure in the last month of pregnancy, and there should be no undefined cause of cardiac failure and no recognizable heart failure before the last month of pregnancy. But additional criteria is your strict echocardiographic indication for checking left ventricular dysfunction, which I have already enumerated. I will not discuss again. And if all these findings meeting the diagnostic criteria, so patient will have a diagnosis for PPCM. So what you have to do, a good consultation between cardiologist, obstetrician, and perinatologist is required. So diagnosis is always made before the woman gives a birth, and it involves an anesthesiologist and a neonatologist also, or you may consider transfer to a higher perinatal center if you doesn't have adequate infrastructure. Now coming to the other part, that what will be the etiologies, probable etiologies. So viral myocarditis may be one of the cause, and then onset of symptoms may be later than 32 weeks of pregnancy. It may be there, but autoimmune disease and viral myocarditis is one of the etiology for PPCM. And now the another point was that these what are the predictors of poor prognosis? So these are the predictors of poor prognosis. So if a patient has a lesser ejection fraction, for diagnosing less than 40%, but for poor predictor, if the EF is less than 25%, or if your left ventricular in systolic dimension is more than 5.5 centimeter, again the prognosis will be bad. And if the QRS timing is less than 120 millisecond, again the prognosis will be bad. And if the patient has following a subsequent pregnancy, so these are all of the findings that peripartum cardiomyopathy have a poor or worse prognosis. And 50% of the women with PPCM recover to their baseline functions or more than 50% improvement within the 6 months after presentation. So it has got a good prognosis also, but these are the few factors where prognosis depends on these findings. Now, 1 or 2 points related to the treatment part also, that why these prolactin, because what you see that in PPCM, the prolactin concentration are very, very much elevated, and this induces the breast milk production. And there are always chances for increasing in oxidative stress. And because why these oxidative stress is increased? Because of the increased production of prolactin derivative, mostly which leading to endothelial cell apoptosis, as well as disrupting the capillary structures as well. That's why bromocriptine and cabergoline has proved a good potential for treating those PPCM. Why? Because it indirectly suppresses the prolactin. But only you have to keep it in mind that bromocriptine has some side effects like myocardial infarction, or it can cause cerebrovascular accidents, or sometimes can cause severe hypertension as well. So now coming to the board regimen. So it consists of B for bromocriptine, O for your oral heart failure drugs, and A for anticoagulants, R for relaxants, and D for diuretics. So this board regimen is especially used for peripartum cardiomyopathy, in which oral heart failure drugs like ACE inhibitors and beta blockers is utilized for treating your peripartum cardiomyopathy. And then you may use early anticoagulation in prophylactic dose, and then relax as a vasodilator. IV vasodilators could be used. That's why the board regimen as a mnemonic has been written. In one of the publication in paper journal, it was there. That's why I thought I should add it here, so that you all guys know that what is board regimen, just like for remembrance, that how it is going to help in treating PPCM. Now coming to the next part, question that magnesium sulfate therapy in preeclampsia. All the statements are true, except I will not go in details, because we all know that all of the following findings are true, except Here, if you'll see, the option is B. B is only the statement that is not true. Rest all other statements are true because respiratory paralysis occurs at a value as a magnesium value of more than 7.5. Target serum magnesium for treatment we require 2 to 3.5. And anti-convulsant action is blocked by blocking the NMDA receptor while using magnesium sulfate as a therapy. So I will be not dealing it in much. But now coming to the next question, a 30-year-old male 36 weeks, pregnant female was there. Yeah, she presented to emergency with headache, nausea, vomiting, and weakness. She is lethargic on examination, blood pressure 150/80, heart rate 112, and respiratory rate was 21, temperature was 38 degrees Celsius, saturation was 0.97, chest X-ray and abdomen examination were normal, and she found to have a MAHA, that is microangiopathic hemolytic anemia. Platelet count was only 42,000, and she was diagnosed with TTP. Now you have to pick a true statement. Who's going to mark it? So what will
Is
be
it true or false or single
only
best
only
answer?
only one statement because we are right now we are discussing a type A question. Na? Good. Good. I think you marked it right. It's a plasma exchange. It's the best immediate treatment that we will follow in this patient. Now what I thought that I should add one slide related to your TTP management in pregnancy. So I thought that I should use this slide. So if a patient is having a MAHA with thrombocytopenia, especially in pregnancy or postpartum, what you have to do? So you have to conduct a urgent hematological and obstetric evaluation. So for what the information you required? You want to know the gestational age. You want to know the whether which organ I have to means prevent it from damage like brain, kidney, or liver. Whether there is any ongoing autoimmune disorder is there, or any infection, or any drugs is there or not. We have to assess the fetal-placental status. If you know all these important findings, then after that you have to go with some trimester or postpartum values of platelets, whether it is less than 30,000, creatinine less than 2, AST/ALT, whether it is equal to 2 upper limit normal or normal blood pressure. So if all these findings are there, so you can make a diagnosis for clinical diagnosis of acute TTP. Here, the diagnosis has already been made as acute TTP. Otherwise, you may be make alternative diagnosis like your HELP syndrome and hemolytic urine syndrome and DIC and then acute systemic vasculitis. But now here the crux is that if you make a diagnosis of acute TTP, so definitely you can go adding plasma exchange therapy and then steroids. And then if the patient is going to get delivered, so if obstetric indication and or no advanced disease, so you can definitely go for a delivery after doing a plasma exchange therapy. But what happens that most of the time you go with the ADMATS 13 activity. So for seeing the levels of ADMATS 13 activity, what happens that most of the time if the values falling below 10%, so it can give rise to two different aspects, that your acute TTP and your congenital TTP. So here what happens that antibodies should be positive for acute TTP, and for if antibody is negative, so it is congenital TTP if you have ADMATS value less than 10%. But if the ADMATS value is very high, it's more than 20%, so you have to make an alternative diagnosis of HELP syndrome, HUS, or DIC, or acute systemic vasculitis. So why I have added this slide? Only to give you understanding that not only directly if your clinical findings or laboratory findings is mimicking with the diagnosis for acute TTP, or then you must check the ADMATS activity whether it has been given there in the question or not. If it is given there, you may think of the alternative diagnosis at this point of time, and you can differentiate your acute TTP either acquired or congenital based on the ADMATS findings only. So that's why this slide was important. Now coming to the next question, that regarding HELP syndrome and eclampsia, which of the following statement is false? Now this again a simple question, one liner. We all know that this statement like eclampsia describe any seizures during pregnancy. This statement is not regarding HELP syndrome and eclampsia. Rest all a statement are true, like HELP syndrome is a mild variant of preeclampsia. HELP syndrome can occur without hypertension. HELP syndrome consists of hemolysis, elevated liver enzymes, and low platelet count. So here I thought that I should add here the Mississippi classification. You all understand that what this classification is all about. Basically, this classification talks about the severity of the HELP syndrome, where you have a class 1. Here, the class 1 is more severe, right? because here the platelet is less than 50,000 and AST and ALT level is also more than 70 and LDH is very high. But in class 2, the platelet varies between 50,000 to 1 lakh, below 1 lakh, and rest other findings is normal, almost. These two findings are normal. And in class 3 also, these two findings are normal. Only one change is there, that in AST or ALT, the value should be more. Here, the value is more than 40, but in class 1 and class 2, the AST or ALT value should be more than equal to 70. Rest other findings are same, but they can ask that which class is more severe, like class 1 or class 3. So most of the time, if you are not read properly, so might be you are marking it class 3, maybe the more severe one. But here only the class 1 that is more severe, that you have to understand. And then here the platelet count is less than equal to 50,000. So this is all about type A question. So if you all guys have any query, we can discuss, or I can go ahead. Okay. Chalo, ठीक है. So I will be moving for the type K question. Now here you see the type K. Here you have to mark true and false statement both. So you have to pick a false one also, and you have to pick a true one also. So the first question, which of the following is diagnostic criteria that are present in acute fatty liver or pregnancy? So again, I have put the same question to know whether you all guys understand the term or know the values of Swanson's criteria or the factors for Swanson's criteria or not. So this question is directly based on that criteria only. So that's why your two statements like your coagulopathy and hyperammonemia will be there, but these patient doesn't have any very high triglycerides level, or hyperglycemia is also not present. Here, these are the features. I will just not repeat this slide. Only for, again, for your better understanding, I have added this question so that you can know that no hyperglycemia and no hypertriglyceridemia is there, but patient will have polyuria, encephalopathy, or polydipsia types of thing. And you must remember that these patients have microvascular steatosis also. Now coming to the next question, again a question related to your physiological changes in pregnancy. Which of the following statement are true regarding physiological changes during pregnancy? So systolic blood pressure drops about 10 to 15%, heart rate drops about 15 to 20 beats, and left atrial enlargement with caudate rotation, and left sheet of maternal oxygen dissociation curve. I think this is a very simple question. Here, the first statement, like systolic blood pressure should drops by 10 to 15%. Rest all other statements are not true as physiological changes of pregnancy. Now here, if you'll see only 2 or 3 points, that what will be the dramatic changes of physiological changes in cardiovascular changes. So blood volume, we all know that blood volume increases progressively up to 50% in singleton pregnancy. And placental vasculature, so it mostly depends or it encounters around 30% of the cardiac output, so almost 600 ml per minute at term. And out of this, 16% of the maternal blood volume is located in the uterus at any time. So again, this is a small liner, one liner, that how much percentage of the placental blood is present in the uterus at any point of time. So it is around 16% of all those values, all those maternal blood volumes. And then the blood pressure usually declines during the first trimester to an nadir value, typically 85 to 110 and 50 to 70 millimeter of mercury in the second trimester. And these blood pressure returns to normal to pre-pregnancy value in the later part of third trimester of pregnancy. So I thought that I should add 1 or 2 different highlighting points. That's why I have added. Now coming to the next question. So again, a question is related to the resuscitation. During resuscitation of obstetric patient, mark the true and false statement. So first, a definitive airway should be secured as early as possible, as there is increased risk of aspiration. You can use a left lateral tilt, is not applicable to avoid aortocaval compression, and perimortem cesarean should be done within 4 minutes of cardiac arrest, and IV cannulation is preferably avoided below umbilicus. So again, this is a straight question, I think. Anyone who want to attempt? So you have to mark true and false.
Yes. The first one is true.
Okay.
False. After that, true.
Okay.
And the last one, false.
Okay. So I think Archana has also marked, and Adil also you have attempted. Good. So here, your this statement, I think this was a straight one. This was a not true at all, because you always need a left lateral tilt, and it is always applicable to avoid aortocaval compression. Here, because we have to mark true and false statement. Rest all other statement is true. Here, only one confusion is there, that if perimortem cesarean should be done within 4 minutes of cardiac arrest. Now, if you see the recent AHA 2020 guidelines, so here what they suggest, that how will you going to approach these patients? Just I will revise very quickly, that if the patient is pregnant and underwent a cardiac arrest inside the hospital, so high quality CPR defibrillation, everything is important. So you assemble a cardiac arrest team. So consider the etiology for the cardiac arrest team. These are the four different important findings that we have to take care of, that we have to perform the airway management, we have to give oxygen, we have to place IV above the diaphragm. We have, if the patient is receiving a IV magnesium, then stop and give calcium gluconate or calcium chloride, and then continue BLS or ACLS. So this is fine. But here, to perform the obstetric intervention, you need to provide a continuous lateral uterine displacement. You need to detach the fetal monitors, and then you prepare the patient for perimortem cesarean section. So here, this question is very important. This line, that during arrest, if the patient is already having fetal monitors, so you have to detach that monitor, and then you have to put that for putting that patient for or taking that patient for perimortem cesarean delivery. Here, if ROSC is not achieved in 5 minutes, so this is what AHS says, but as per European guidelines, they talks about 4 minutes also. So 4 and 5 minutes is the timing for the perimortem cesarean delivery. If the patient is not getting ROSC within 5 minutes, so you have to immediately go for perimortem cesarean section. So I will be asking that, if you just read that question carefully, what they want to ask. If they directly want to ask the perimortem cesarean delivery, when you will do, whether they are asking that if ROSC has been not achieved within 5 minutes, then the option would be right, and or you must see the options very carefully. So these are the few important point, and apart from that, you must place these advanced airway. Only you want to place advanced airway in place, then you have to give 1 breath every 6 seconds, or 10 breaths per minute with continuous chest compressions. Rest everything is fine, and rest everything we all know. Here it will be not going to get asked, but maybe you have to remember the ABCDEFGH mnemonic, that what this is all about, because here G is the general non-obstetric cause, that 5H and 5Ts, that what we used to read. So now after that, you have to send this patient for a neonatal team to receive that neonate. So this is all about your pregnancy part. Now coming to the again a one-liner question, that most commonly found organism in sepsis of obstetric patients. So here also, if you see, the option would be the E. coli. Yes, this is one of the organism responsible for sepsis in obstetric patient. Apart from Bacteroides fragilis, rest all can cause sepsis in obstetric patients. Okay. Now coming to the fourth, so trauma in pregnancy, again, one of the aspects they may be going to ask this question, that trauma related to pregnancy. So you have to identify true and false statement. Again, it's a one-liner only. So ultrasound is not useful at all for screening. So must read that all options very carefully also. Not useful at all for screening. NT-D or NT-D immune globulin to be given to all RSD negative women of childbearing age after abdominal trauma. And it is easy to differentiate between placental abruption and uterine rupture clinically. If chest tube placement is indicated, it should be placed 1 or 2 spaces lower than the normal. Okay. So here also, the only statement that is true is your B. So you must give NT-D immune globulin to patient who are RSD negative women of a childbearing age after abdominal trauma. So this is one of the important facts that we have to remember in all groups of RSD negative women, childbearing age. So you have to give NT-D immune globulin. Rest other options doesn't fit to the right criteria, because it is not very easy to differentiate a placental abruption and uterine rupture clinically, and chest tube placement, if indicated, should be placed one or two spaces lower than the normal. No, it should be placed normal. Now coming to the next question regarding VT in pregnancy, venous thromboembolism in pregnancy, mark the true and false statement. Here the incidence is same to that of non-pregnant state. First, pulmonary embolism, the leading cause of death in developed countries like US and in Europe. 80% of the DVT occurred in third trimester, and 40 to 60% of the pregnancy-related episodes of P occur in the purpurium. Okay. Now, again, this statement, pulmonary embolism maybe is the leading cause of death in US and Europe countries. So, because the exam is EDIC, so European Diploma in Intensive Care, so maybe pulmonary embolism is the leading cause of death in developed countries like US and Europe. So, this statement is true, and this D option, this statement, like 40 to 60% of patient pregnancy-related episodes for pulmonary embolism occur in purpurium state. So why I have added all those questions? Only to understand, only to know that, okay, these are the facts that I have to remember. There is no concept in it that the P is the leading cause, because this is the data that we have to know. That's it. Now, coming to the, again, asthma in pregnancy, again, we have added one thing, that asthma in pregnancy, which of the following statements are correct? So you need a hyperventilation to bring down PSO2 to 26 to improve the uterine blood flow. You need magnesium that can be given in pregnancy. Inhaled corticosteroid and short-acting like SABA are teratogenic, and 100% cases improve during pregnancy. So these kinds of options are always not true, right? So here, the only true statement is your magnesium sulfate can be given in pregnancy. Just before that, we have also read that how good. So I think you mark most of the options true. So first statement is false, second is true, and next two other statements are false. So here, the magnesium sulfate also has a role in, especially in asthmatic patients, and inhaled corticosteroids and short-acting beta agonists are not teratogenic at all. Now, coming to a good question, I think here we need a discussion that mark true and false statement for platelet transfusion and HELP syndrome. So now just read the question very carefully, that you are going to transfuse the platelet for class 1 HELP syndrome before cesarean. You are going to transfuse, or platelet transfusion is suggested for patient less than 25,000 of platelet count before vaginal delivery. So you want to transfuse the platelet before vaginal delivery, or a actively bleeding patient with thrombocytopenia, and all those patients with a platelet count less than 20 should receive a platelet transfusion. Why? To prevent excessive bleeding during the delivery. And D option, addition of platelet transfusion. If you do you want to add corticosteroid therapy to platelet transfusion? Why? Because it will increase the platelet count and improve the maternal outcome in HELP syndrome. And then repeated transfusions are required due to the short half-life of the platelet. So now I want to see that how many of you mark it true and false, right? So it's again a bit tricky question. That's why I've added a. Okay. So you think that first two options are false. Good. So third option, you feel that it's true. Okay. D option is again false, and E option is false. Okay. Good that 2 or 3 people have started to attempt. Now you see that first option is true, and then your third option is also true. I think most of you guys has marked it right. So now the first and third options are true, and rest other options are false. Now you see why. Now, this has been taken from the 3 different guidelines, like from Obstetric Gynecology Survey, Journal of Maternal Fetal Neonatal, and European Journal of Obstetric Gynecology and Reproduction. So first, platelet transfusion is suggested for patient with class 1 HELP syndrome, because we know that these patients, as per Mississippi classifications, have a platelet count less than 50,000. So the platelet transfusion is required in these patients before cesarean sections, or when platelets are below 20 to 25 before vaginal delivery. So here what happens that if vaginal delivery is planned, your platelet transfusion is required only if your platelet count falls below 20 or in between 25 to 20. But for cesarean, you must transfuse platelet if it is falling below 50,000. Now, second point, if the patient is, okay, however, if the patient is actively bleeding with thrombocytopenia, all those with platelet count less than 20 should receive a platelet transfusion to provide excessive or to avoid excessive bleeding or to prevent excessive bleeding during delivery. However, repeated transfusion is not required. It's not required because of the short half-life of the platelets. And these recommendations has been challenged by the various others. So based on that, De Gracia report was there which suggested that if you want to add corticosteroid therapy to platelet transfusion, what it will do to increase the platelet count? No, it doesn't improve the maternal outcome in HELLP syndrome. That is resolution of the HELLP syndrome, which is recognized as normalization of the platelet count and the length of the stay. It is not there with using corticosteroid therapy. That's why this option is not right. So repeated blood transfusion are required due to the short half-life of platelets. No, this statement is not true because repeated transfusion are not required. And second, if you want to add corticosteroid to increase the platelet count, no, it doesn't improve the maternal outcome in HELLP syndrome. And your platelet count for class 1 cesarean section is true because yes, it has to be required. But if needed, the platelet count should be less than 50,000. And for platelet count for vaginal delivery, it is less than 25. It is not less than 25. It should be 20 to 25. Maybe this option is partially correct because if you'll see this part, so it should be less than equal to 25. It is less than equal to 25, so it should not go below 20,000, right? So I think this is the another question. This is the last one. Here you have to carefully mark the true and false statement about the platelet with severe preeclampsia and suspected HELLP syndrome for receiving parenteral magnesium sulfate as a prophylaxis for convulsions. We all know these magnesium sulfate is very effective for preventing or abrupting the convulsion. So here you want to use a magnesium sulfate regimen, 6 gram IV over 20 minutes. You want to give a continuous magnesium infusion of 2 gram per hour starting during the period of observation, and you want to continue 48 hours postpartum. If a patient is having a recurrent seizure, you want to add an additional 2 gram magnesium sulfate given over 3 to 5 minutes. Or if the seizure is not controlled, after 3 boluses of magnesium sulfate, other anti-seizures like diazepam or lorazepam or midazolam can be tried. And ACOG task force recommended antihypertensive therapy for severe preeclampsia and HELLP syndrome if your BP is going above 160 to 110. So just write your true and false statement here. Okay. Not an issue. Even if you mark it wrong, not a problem. You do as many mistakes as you want to do. So I think Neeraj has attempted that. He feels that, okay, Adil feels that all those options are true. And Neeraj feels that first option is false, rest all are okay. Start those. Okay. Archana also marked most of the options true. Now we just see that how the questions has been modified a bit. Why the changes are there? Because definitely we're going to have that guidelines we'll read. But just I want to mark the true statement first. This no confusion was there. I'm sure that every one of you is knowing that this statement is right because is correct because 6 gram loading dose over 20 minutes is the ideal. And then after that, I think option number C. So if you have a recurrent seizure, you have to give additional bolus doses of 2 gram magnesium sulfate, and it has to be given over 3 to 5 minutes. And then if your patient is, as per your ACOG guidelines, if a patient is having a 160, 110 blood pressure, always start antihypertensive therapy. So I will just go in details. Just wait. I think it will be cleared soon. Don't worry. Just I will explain one by one here. Again, the reference is from here only. So, or the patient with severe preeclampsia or suspected HELLP syndrome should receive parenteral magnesium sulfate as a prophylaxis for convulsion. No question. So the magnesium sulfate regimen include a loading dose of 6 gram over 20 minutes, followed by a continuous infusion of 2 gram per hour, starting during the period of observation, and you have to continue until 24-hour postpartum. Okay. So good. So Adil has, I think, made right that 24-hour postpartum, it has to be there. But if the patient in between has a recurrent seizure, so what you will give? You have to give additional 2 gram of magnesium sulfate. That can be given over 3 to 5 minutes. But always do a close monitoring because we have just read one question that how these magnesium toxicity is going to affect the knee jerk, urine output, or they may present acute kidney injuries features as well. And third point, if seizure is not controlled after two such boluses of magnesium sulfate, you must try diazepam, lorazepam, and midazolam. And last, the ECOG, sorry, here you can see that last for starting antihypertensive therapy, ECOG task force recommend antihypertensive therapy in severe preeclampsia. The value should be 160 to 110 and HELP syndrome if blood pressure is 160 to 110. So this is all about your adding your antihypertensive therapy. So I'm sure that now we just look at again these options. Yeah. So I think this question, if you'll see that all these explanation has been there, that how this is going to affect your, just a minute. Okay. So here also ECOG task force guidelines, it suggests that that antihypertensive has to be started with help. Just see, with help. With health syndrome, if BP is going 160 by 110, you have to start. Definitely you can add three boluses. Here, three boluses is not there. Two boluses of magnesium sulfate is there. So again, this option is not true. But definitely you can use other anti-seizure drugs. And then recurrent seizure, you can give an additional bolus of 2 gram of magnesium sulfate. So this is all about from my side, and very best wishes to all of you for upcoming EDIC examination as well. And again, these are the not the question that will be directly coming in your EDIC examination, but only as a part of sensitization. I have added few questions. Might be you have not seen in your presentation, or what you have got that mock test to all the questions. That's why I have added 2 or 3 new questions to it so that we can have a more discussion on that. And till this point of time, if you all have any question, definitely you can reach to me, or you can write to Forge Academy for the questions related to my topic. Definitely, I will be going to help you all, or I will give you a proper explanation for that, that from where I have taken all those part. Still today also, most of the part has been taken from the packed module of the EDIC, and few of the questions has been taken from the journals, and few of the questions have been taken from the Irwin also. So this is all from my side. And if you don't have any questions.
Thank you, sir.
Thank you.